Hello, welcome back. Today I am joined by Dr. Alastair Jones, who is a sports medicine and MSK physician based in Yorkshire. Al, how are you doing?
I'm good, thanks, Andy. How are you?
Doing very well, thank you. Doing very well. What's on the agenda for you today?
Today's a Tuesday, so it's my working on other projects day. I'm out the NHS today, so it's looking at other things that I'm doing that I'm sure we'll get into, and the odd little bit of life admin, which is always good to catch up on.
Absolutely, definitely. No, well, thanks again for joining. I'm really looking forward to having a chat with you and hearing more about your story and what your plans are for the future.
Great stuff. No, thank you. Thanks.
Great. So in terms of your background, whereabouts are you from originally?
Yeah, so sort of Yorkshire born and bred, really. Born in Leeds in Adel, and sort of grew up there all the way up until I went to university. Went to Leeds Grammar back when it was in the city centre before it moved out to where it is now. And no doubt that helped me get into med school, because I don't think I would have done it if I wasn't sufficiently pushed and whipped as I was there. So that was useful. And I went to uni in Sheffield, did sort of med school there for 5 years. Spent a year after med school working in Sheffield, and then came sort of back to Leeds, sort of from a family and friends point of view, and sort of worked around Yorkshire until I finally settled into a consultant job in Bradford.
Yeah. And what made you want to do this line of work in the first place? Like, what were you, when you were thinking of your A levels and things like that, was that always on the pathway to become a doctor?
Yeah, I wanted to be a vet when I was younger, but I'm allergic to cats. So I thought, well, we'll go for people instead then. That try and make me a bit more comfortable working environment. So I've always been interested in, I'm going to give you the med school answer here. I've always been interested in biology and chemistry and all that kind of stuff, but quite like helping people as well. So all the usual med school stuff, but also I thought being a doctor was quite a steady, stable career that didn't require a lot of sort of chopping and changing and kind of worrying about jobs. If I got through the medical school degree and got to be a doctor, I'd be employed for a while, and that would be a bit of pressure off too. So. But yeah, I ever since I can remember, certainly ever since sort of GCSE age, I've kind of been tailoring the subjects I did into subjects that would help me get into med school, and then from that into med school. So I don't really. I mean, my mum was a nurse, and she was a practice nurse for many years. My dad had absolutely nothing to do with medicine, although weirdly at the end of his career he works for a sort of a company that makes fabrics, and they ended up making material for Aquacel, which is a wound dressing. So he got into that at the very end of his career, but he had otherwise no medical kind of faints at the sight of blood kind of stuff. So, and there's no other sort of medics in the family. So I think it was just a bit of it looked quite a good job, and I'll go for that kind of thing. There was no specific one thing.
Yeah, and then you mentioned the grammar school then. So how many other people went into doing medicine from there? Was that something that was guided through that school as well?
Yeah, so they push you to do all of the sort of those kind of jobs, really, I guess. I don't know whether it's different now. So there were a lot of medics that went. In fact, I had sort of 6 really close friends at the grammar school that I'm sort of still in touch with most now, and out of those 4 went on to do medicine. So yeah, sort of law, medicine, all that kind of stuff was kind of push. I mean, I'm grateful to my folks for it. It was a wonderful opportunity, and it cost them an absolute arm and a leg, which I know they worked really hard for. But like I say, I think I needed that kind of. I think now I'm more sort of ordered and kind of quite driven in my character. But back then I wasn't. So I needed, if I was going to ever do something like medicine, I needed to be pushed, which they did for me.
Yeah. Well, I was actually over at Sheffield Medical School yesterday for the conference we were at. So,
right.
So that's quite interesting. And then, so how did you find your time in Sheffield?
Yeah, I like Sheffield. So I just spent all of the sort of the 5 years living there with sort of various housemates in sort of various different parts of sort of the student areas of Sheffield, if you like. But I quite like the campus. I quite like the university and the things that were on offer there. I was into swimming back then. I used to swim for the university, so that took up quite a few of my evenings and stuff. And the occasional weekend going away. So that was a really good time. But the actual medical school itself was, for whatever reason, the teaching style sort of suited me. The lecture patterns, the way the week worked, seemed to work really well. And then I think I was lucky. I just had some really good placements on the wards and in the clinics. I really enjoyed pretty much all of it, to be honest. So yeah, no, it was a good experience, university, mixture of social stuff along with learning, and got out with a degree in medicine, which was the goal.
And then at what point were you starting to formulate what end goal you wanted to do, or like what role you wanted to do?
So the role I'm in now is not the role I started out at. So a bit like from school, I wanted to be a doctor from a young age after the vet thing fell through. And I drove towards that sort of with all the subjects. So in med school, pretty early on, I knew I wanted to do A&E. And so I did a couple of things extra in med school in A&E when you were allowed to choose certain placements or certain projects. And then tailored, obviously, the jobs after med school towards A&E. The first year was sort of pre-registration year, where you had to do 4 3-month jobs in sort of medicine and surgery. And then after that, I did a sort of a 6-month non-training job in A&E at Jimmy's in Leeds. And after that, I jumped onto the Yorkshire rotation for A&E, which included things like paediatrics, orthopaedics, A&E, obviously, medicine, and then straight into the registrar's training scheme, and worked my way up in that, and sort of qualified as a consultant in 2011 in emergency medicine. And then pretty much as soon as I qualified as a consultant in emergency medicine, I realised I didn't want to do emergency medicine, which was a bit of a bit of a shock, I think, to sort of family and friends, and then so I spent a few years working out why I didn't want to do, a couple of years working out why I didn't want to do emergency medicine, what was wrong with it, what was wrong with me to not want to do it anymore, after basically spending a good 8 or 9 years of my career training up and doing all the work and all the exams that entails. And then realised that I really enjoyed some of emergency medicine, just not a lot of it. And the bits that I enjoyed was the musculoskeletal medicine, the trauma, and then more so now the MSK management, the injured joints, the injured muscles, and then also working in sport, because from my junior registrar years, I started to get involved with sports teams. So I first worked for Doncaster Knights, Rugby Union team, and did some game cover for them, and then progressed on from there. In fact, I remember the first game I ever covered for Doncaster Knights was away at Exeter, when Exeter was still in the Championship. In fact, that was the last season they were in the Championship. They went up that season. And I couldn't go down with the team on the Friday because I was working, so I had to go down on the Saturday. And so the owner flew me down in his private jet. And that was the first game I'd ever covered in rugby. And I thought, well, if this is what sports medicine's like, I'm okay with that. That's never happened again, and probably never will happen again. But it was quite a good induction into rugby. And then I worked there for a couple of seasons before I then got sort of into the Rhinos, which I'm sure we'll talk about in a bit. And just as I did more of it, realised this is absolutely what I want to do. But I didn't really want to fully leave emergency medicine or A&E at that point, because of all the work I'd put in, and the colleagues and the friends that I'd sort of formed there. And so I thought, well, how can I mix the two? How can I design a job where I'm still doing stuff that's helpful for the ED, but is going to keep me in medicine? Because I got to the point probably 5 or 6 years ago, I was thinking, I don't really want to. You wake up in the morning, you want to go to work, and that was a bad place to be. So changed dramatically then, and now actually I absolutely love going to work through the stuff I'm sure we'll talk about.
Yeah, no, that's great. That's really good if you end up absolutely loving what you're doing. And then, so in terms of prompting the sport move, what was it in particular that made you get into that then?
So yeah, like I said, worked for Doncaster Knights, and the way I got into that was my supervisor at the time was another A&E consultant, and he had a sort of vacancy that they had a medical at Doncaster, and he had a vacancy to work pitchside there, and pretty much the first game, not because of the flying down there, but just standing on the pitch side, looking at these sort of amazing athletes, and then being able to provide some sort of service towards them. Also, it's a very different environment. Working in sports teams is just completely different to working within a hospital setting in terms of the way that the hierarchy of where the doctor fits in versus what he's expected to do. So that really interested me. And then the injuries that were coming were excellent injuries. They were things that I really enjoyed diagnosing and sort of helping manage. I also really enjoyed the fact that sort of sports people, they really want to get better, and they really will listen to you, which isn't always the case in other walks of medicine. So that pushed me. And then, like I say, I just moved sort of slowly from covering games. If you sort of look at the sports medicine stuff that I've done, I started purely, as most people do, covering games, covering pitchside medicine. And then I moved into sort of providing a clinic. I moved from Doncaster to Leeds Rhinos. And I started to do game cover there in the academy, moved to the first team, and I started to provide a clinic a week. And then I think it was either 2016 or 2017, I can't remember now, I got the head of medical job at Leeds Rugby, which actually at that point entailed Leeds Rhinos and Yorkshire Carnegie, who were a Championship Rugby Union side that have since sort of dissolved. But that was really busy. It was excellent. Over 200 players on the books there when you were taking into account all the academies and both teams. So it's really busy. Bunch of physiotherapists and sports therapists to work with that were all great. So I really enjoyed that, but it was extraordinarily time consuming because nobody plays rugby at 12 o'clock on a Tuesday afternoon. It was all weekends, all out of hours. And of course, quite rightly so, with elite sport, tomorrow isn't good enough. Everything has to be done straight away. So eventually ended that in, I think, 2018 to move more into the MSK side of things, both in the NHS and the private sector. But absolutely love sport. I still do some sport now. I still do Leeds Rhinos netball now, actually. So I'm still with the club. Been there for about 12 years now, I think it is. That's great. That's a mixture of elite athletes, but a much smaller squad, and allows me to do all my other stuff, but still keep my hand in sort of elite sport, still up to date with all the protocols, concussion, everything else that you might want to talk about.
Right, yeah. So was that at the Leeds campus that used to flood quite regularly?
Yeah. So that was a very interesting year when it properly flooded in 2015-16. Got a great picture of the doctor's laptop floating on the water in the medical rooms. That completely ruined Kirkstall for a good year. So we were training. Carnegie went up to West Park, and the Rhinos went sort of all over the place, for both gym sessions and on the field training. It was a huge undertaking by everyone there, because your entire base, your entire week was ruined, and then it just kept changing. Weekly new schedules come out with we're here then, now we can't be here, we're here there, and then they're going and playing games. It was a nightmare really I mean, I had it easy. I just had to turn up where I was told to go and just do the same job. But for everyone with the logistics, that was really hard.
Mm. So were you working with both teams then? You were involved with both of them. So did they have their own physio teams and sort of?
Yeah, Carnegie and Rhinos, aside from the doctors, were entirely separate. So obviously certain different coaching staff, obviously different physiotherapists, different sports therapists, and then just the medics were the same. So I was fortunate again. I worked with a couple of really good doctors. Vas Mani, who is there now, who's their head of medical now at the Rhinos, and Ronnie Banerjee, who's also there at the does Hull City as well, football. So I was lucky. I was supported by two great people, and then we had a bunch of other doctors who would provide pitchside care, much like I did when I started at Doncaster all those years ago. So back when I sort of did the head of medical gig there, I was still relatively heavily involved in emergency medicine. So I had access to lots of registrars, and we sort of always said, sort of in a sports team, if you can have a combination of a sports medic, an emergency medic, and a general practitioner, then you've got pretty much a great doctor there that can do most things that a club's going to want you to do. So the ED part of it, obviously from a pitch side point of view, if someone's going to break a leg or have a spinal injury, you want an emergency doctor there to help manage that. So I had access to registrars that were very keen. It was about the same time that I was setting up the fellowship program at Bradford as well for the MSK service. And so everyone that came through that, or the trainers that came through that, would help out down at the Rhinos, which was very useful.
Yeah, and so how did elite sport compare to like your preconceived ideas before going into the actual reality of it?
Yeah, I think probably a lot of people say this. From the outside, you think it's just that. You think it's elite. And in lots of areas it is. I mean, the athletes are phenomenal. I remember standing on the touchline at the Rhinos in one of my early games there and sort of watching Ryan Hall run down the wing, and just imagined myself 2 meters further over to the left, standing in front of him and thinking, I wouldn't get up again. You know, they are phenomenal athletes, what they can do, the skill as well as the power and the speed that they have. So that the eliteness of them is brilliant. But the organisations have the same problems that every organisation does, from the NHS to the private sector. I remember I was very, very lucky. I covered Tonga in the 2013 Rugby League World Cup, and that was a wonderful experience. That was 5 weeks that I'll never forget. The people were amazing, totally different sort of type of people. The Tongans coming over, very family orientated, very religious, really good to get kind of in and amongst them. But on the first game, they forgot the kicker's kicking tee, which I sort of thought, how can that happen to the World Cup? And the kicker now hasn't got a kicking tee and no spares, so they kicked off a cone, which just staggered me. And so the thing that probably struck me the most is that whilst the people in it are really quality, the organisation, the systems still fall down unless your communication links are absolutely there. So that was probably the biggest thing that struck me. Other than that, yeah, it was great. I mean, it was very, very busy. Not sure I thought it would be as busy as, certainly when I got to the heavy metal, as it was. Knew it would be very busy, but the pressures on you are huge, particularly around sort of when you're losing. So I was extremely lucky in my Leeds Rhinos career. I took them through the golden generation, as it was called, with your Kevin Sinfields and your Robbie Burrows and Danny Maguires, where they were winning everything. And then they all retired to where they were losing most things. And it's a different mindset then in a team when that happens. So yeah, a lot. I mean, the lessons that I've learned that then I've been able to transfer over to the NHS and the other clinics I run are invaluable.
What sort of things would they be then? So
just communication is, I say this all the time at work in the NHS and to colleagues and trainees. The almost always the reason that a system fails or an organisation comes into difficulty is communication falls down. You can manage most problems as long as everyone's aware of the problems and you have the right team to sort of solve them, which hopefully build up together. But if someone doesn't know, if player A or Dr. A doesn't know what Dr. B is doing, if the managers aren't on the same page and no one's talking to each other, it falls down really quickly because A, the problem doesn't get solved, and B, everybody gets very annoyed and upset with each other because they're not pulling towards the same goal. So communication was absolutely huge. Leadership, I learned a lot about leadership from some of the people that I work with, both in terms of the players. So I had the benefit of listening to Kevin talk most weeks in the changing room, and he just, he had command of the whole changing room. They listened when he talked, which was fantastic. Not the same with a lot of sort of clubs I've covered for. And then the staff, some of the staff around the building, both from a coaching perspective and a support staff perspective, the way that they handle themselves and led, I took a lot of tips away from that in terms of how to manage myself in situations that are perhaps not going the way I want them to do. So the non-technical skills. Yes, I've learned lots about medicine. I've learned lots of different things we can do to muscles, tendons, joints to get people up and running again. But that's not as big as the non-technical stuff.
Yeah, well, you mentioned Kevin Sinfield. I saw him running in Didsbury actually on his thing. It was like about 6:30 in the morning, just two guys. So it's pretty remarkable what he's been doing. I mean, you've been close to, you mentioned both guys there. How have you, how have you found seeing what's happened with Rob Burrows?
Yeah, it's really sad. Obviously, it goes without saying. I was a doctor for Rob for many years, sat on the sort of touchline with Rob. I remember taking Rob off with concussion on a number of occasions and sort of managing through the process. I remember talking to Rob about all sorts of things not sport related, and then as he moved into the academy and started coaching, working with him from a backroom perspective then in terms of sort of managing players and injuries and stuff like that. So to see him, go through what he's going through now is tough, but on the the bright side of it, that what Kevin's done for him and continues to do for him, along with everybody else at the club, because absolutely everybody is behind him, it's just utterly phenomenal. So yeah, it's I think his wife and children are absolutely fantastic. I think he's still probably he was, and I'm sure he still is, unbelievably positive, Robbie. Absolutely unbelievable. Every time Brian McDermott would say in the change room at halftime, "How are we all feeling?" Robbie would be the first one to say, "Good, all sweet," without even thinking. He might have lost an arm, it didn't matter. He was fine and ready to go again. So he was so positive. So hopefully he's still got that mindset.
Yeah, no, definitely. And then, so you, what do you do after you'd left Rhinos?
So building up in the background whilst I was still doing that job was this MSK service at Bradford, which is probably the thing I'm most proud about sort of to date, which is I looked at, like I said, emergency medicine wasn't for me anymore, but I didn't want to move out of it completely, and I wanted to still make a bit of a difference. And about 30% of people that come to an emergency department have some form of minor injury or musculoskeletal problem. And if you look around the patch, they're not managed very well. If you break a bone, it's a very simple procedure. You either get admitted because you need an operation, or you get fed into a fracture clinic where an orthopaedic doctor or specialist nurse will either see you or review your images virtually and then take your management forward. And there really is only two sort of outcomes. Whereas if you tear your rotator cuff, if you tear your calf, around the country, you'll see examples of either nothing happening. They might go back to the GP. They might be referred to physio. There might be an A&E clinic. There might be fracture clinic, because that's not the right. None of those places really necessarily are the right place for that person. So what I wanted to do was create a clinic where we could manage all of the soft tissue injuries in patients where if you don't manage them, it's devastating for them from a work and a sport perspective, and bring together expertise into that clinic so we can get the same kind of outcomes in terms of speed and getting these people in front of the right person at the right time straight away. And so that's sort of I had the idea in about 2013, and my first clinic was in 2014, which was myself and a physiotherapist called Chris Liversidge, who's since moved on. And he and I had a clinic in physiotherapy department at Bradford Royal Infirmary, 8 till 12 o'clock on a Wednesday morning. And we had 3 protocols. We had a shoulder one, a knee one, and an ankle one. And we had, I think it was 10 slots in the clinic. And patients in A&E, who the A&E clinicians thought needed following up, would be referred into that clinic, and we would manage them. And then through the last 10 years, that's evolved into what it is now, which is a sort of a genuine sort of soft tissue injury management clinic. There's myself and 2 other MSK physicians who are ED consultants who also work in sport, and we run a clinic every day of the week now. We have a senior physiotherapist, band 7 or band 8A, in clinic with us. We have in-clinic ultrasound, so we can manage the cuff tears, the Achilles tendon tears straight away, so we don't have to send off for imaging. We have links with radiology, so we get next day MRI scanning, which is sort of really useful for sort of queries about locked knees or posterolateral corner injuries, or injuries where we know a quick diagnosis is essential to allow surgery to take place. We have links with orthopaedics. We have 6 or 7 protocols now. We've included the hip, the elbows. We manage injuries around the tendons and muscles in between the joints. And we do some medical stuff. We see quite a lot of the fractures, the fracture sort of bone stress reaction, stress fractures now, because we sort of better set up to manage those than perhaps an orthopaedic fracture clinic would be. And occasional concussion comes by us when they know I'm myself, Emma, or Michael are working. And that progressed over 10 years from that one clinic, due to a number of factors. The thing in my head always has been, if you keep the patient in the centre of your focus, then you can't go far wrong. And so recognising that, if I had fallen over at rugby, torn my ACL, and the stories around sort of colleagues and friends who've done that, where they went to a hospital and got seen in A&E, if they got that picked up, they'd be sent to a fracture clinic, who then referred for an MRI, which might take 8 weeks to organise, then back to a clinic where you then go and see a knee surgeon. The whole process was so convoluted that you could be months down the line without a genuine diagnosis. And of course, we know that if that's the case with things like ACLs, you eventually think, well, I might be all right, I'll have another crack at football, and then you cause more damage. So I wanted to keep driving the clinic forward so that we got the patient in front of the right specialist, whether that be myself, an orthopaedic surgeon, physiotherapist, as soon as humanly possible. We cut down all that increased morbidity, and at the same time save healthcare costs, because you don't have to come back to clinics that the person in front of you is not the right person to see you. And so over the years, I've formed a fellowship program to try and train registrars in A&E to do MSK medicine, because we get quite a good take-up with that. A lot of registrars are looking for something else to do, not just A&E, and that seems to be quite a popular thing to do. And it actually helped me get more clinics, because I said to the management, look, they recognised it was a good thing for patients, but they need to look at the costs and how it was going to benefit the trust. So I said, if I could get you another registrar who could work some night shifts and weekends in A&E, if I could have another clinic, I can train them, and then we progressed it like that. And I remember getting MRIs was a conversation in Costa with the radiographer, the senior radiographer, over just mentioning to her, look, if we could get the next MRIs, we could save this. She went away to think about that, and unfortunately for her, unfortunately for me, she rolled her ankle 2 weeks later and ended up in my clinic. And saw what we did, and that moved that along. So that's fortunate. But I think, like I mentioned before, 20% is about what you know, and being good at what you do, or trying to be good at what you do is essential. But 80% is just persistence. It's just continuing to knock on the doors, continuing to have the goal in your mind and work towards it in small ways, and how you communicate with everybody is absolutely vital. So again, I think I probably learned a lot from sport. So now it's going into this service that we think only a couple exist in the country. There's one in Imperial and one up there in Bradford. And I think if I achieve one thing in medicine when I finally retire, if I can, it'll be to get this clinic in other hospitals, because I firmly believe it should be in everyone.
Yeah, no, it sounds incredible. So what's the typical thing that happens in a normal setting? If I'm in Manchester, say, like how does yours differ to what you experience there?
So I mean, every hospital, every part of the country will have a slightly different protocol of what happens to an injury. So there are examples of the clinic in small pockets in the country. So one hospital somewhere may have a knee clinic, which will work similarly. One may have an upper limb clinic, which will work similarly, but nothing joins them all up that we're aware of yet. So, for example, in Bradford, before the clinic, and this will happen certainly in some of the hospitals in Manchester, maybe all the hospitals in Manchester, I don't know. Let's just take one injury. Let's say you dislocate your shoulder. So you dislocate your shoulder and you go to A&E and they put it back in for you. And then in the majority of hospitals, a dislocated shoulder then goes to fracture clinic. And you generally in fracture clinic, unless you're very lucky, the day you go to fracture clinic, you won't be seen by a shoulder surgeon. It'll be a foot and ankle guy or a knee guy who's running fracture clinic that day. So they'll then refer you to a shoulder surgeon, who will then see you and refer you on for any imaging that may be required, whether that be an ultrasound, an MRI or an MRA, and then bring you back after that imaging is done, and then decide, right, we can surgically do this, or we don't need to, therefore physio. And so you've got 5, 6, 7 points of contact there that the patient has to go through. So if you come to Bradford now, you'll dislocate your shoulder, you'll get it put back in the emergency department, and they'll refer you to the MSK clinic. And in that clinic is myself or my colleagues, an ultrasound machine, and a very senior upper limb physio, because we get the shoulders back on a Thursday, which is our upper limb day. And so in that one clinic, you'll be assessed and have whatever problem that you dislocate shoulder diagnosed. You'll have whatever instability we can clinically pick up diagnosed. If it's a person who's above 40 years of age, you'll have an in-clinic ultrasound if necessary to look at your cuff. If you need an MRI, we can get that the next day if you're within 7 days for an autoarthrograph, or we can refer you for a quicker MRI if we need to. And then you'll be seen in that clinic on the same day by our senior upper limb physio, who can start some rehab going with you. And then once we get all the investigations back, if it is an MRA, we can then decide whether surgery is the right route or whether we keep you with the physios over at St. Luke's, which is the rehabilitation gym. So you cut down 2 or 3 appointment slots for the patient, which obviously it gets them a diagnosis quicker, it gets the correct management started quicker, it only sends operations or what we feel maybe needed to be considered for an operation to the surgeons, so freeing up their time, and it saves obviously all the healthcare costs associated with referring for investigations, because we do it in clinic. So that's kind of one example of many about how it sort of streamlines care.
Yeah, no, it sounds great. Sounds really good. So it's quite a private setting environment, really, isn't it, that you've created, but access to everyone.
Yeah, that's pretty much. I mean, yeah, it's pretty much what we sort of. I think probably what I try and do is look at a gold standard, and then go for that, assuming I'll never get the gold standard, but at least if I shoot for that, then I'll get closer to it than if I start off by saying, well, I'll never get that, I'll start lower.
Yeah.
Works so far, might not.
Yeah. No, I think it's a good philosophy. It's a good one to do. And so then for you, when did you start doing your sports medicine training?
On the job since Doncaster Knights, but then formally I did a diploma at the University of Bath. I think that was 2015-16 I did that. I did, shortly following that, I took the sports medicine exams, the MFSEM exams, and got through those. And then I qualified 2 years ago with ultrasound. I did another postgraduate qualification at the University of East London for ultrasound. So it's been a piecemeal sort of, again, sort of, I did what the thought when I started to really realise A&E wasn't for me was, do I go back to training and go and try and get a sports medicine registrar post? But I was too far into it with mortgages and children and all that kind of stuff, really, to sort of go back to training. So I looked at how could I do this while still working, but still qualifying to be able to do what I do. So I've got sort of 3 extra qualifications now that allow me to do the job that I'm doing.
Yeah, no, it's good because it's not massive, is it? The sports medicine professionals group. We were talking about this the other day in terms of there's certainly in the north there's not loads of you.
I think you could probably name, certainly in Yorkshire, everyone on the fingers of 2 hands that work in MSK and sports medicine in a more longer term sort of role. Yeah, everyone pretty much knows each other because it's so small. You go down to London, then it's much more commonplace. And I think also the setups down there, certainly privately, are much more geared to that. If you go into the 40s clinic, for example, they have a very set, streamlined pathway of orthopaedic surgeons and sports medicine doctors. Whereas if you go into most private setups up north, it's very heavily orthopaedic with occasional MSK sports medicine doctors sort of sitting in, and the pathways aren't quite as formalised as they are down in London. I think that's just because there's so few of us up north. But I think that may change going forward, because certainly from Bradford, I mean, I think I've had 5 fellows now come through the fellowship programme, all who have sort of aspirations of doing half and half, or even less from an A&E point of view to sports medicine. So there may be more people coming through that end up doing this. But I think the actual formal training numbers for sports medicine, and I don't want to speak out of turn because I don't really know, but I think it's less than 10 in Yorkshire. There's less than 10 sports medicine registrars. So, over 3 years, there's not many consultants coming out.
Yeah, no, it's interesting. And that development, we were over with the registrars training day a few weeks ago over at MIP in Manchester. So yeah, no, it'll be interesting to see how that world develops. And then how does this all link in with you've got a few things going on with your private work. So how do you like, do you have a vision of a breakdown of what percentage you want to spend on certain things?
Well, yeah, but not because I sat down with a piece of paper and worked it all out. Some of it I've sort of shaved a little bit of my NHS time off. So I work 85% NHS now, and then looked at because I do jobs that require me to be there, such as the NHS jobs in clinics, the clinics at the Yorkshire Clinic and Nuffield. I need to obviously be there to see the patients, and then there are jobs I do that I can do from home. So working on recovery, I know we'll touch on in a bit, and working started to connect health out a little bit with looking at developing these soft tissue clinics around the country, and some stuff I do with Leeds Rhinos netball now, because the way that the funding structure set up there, a lot of that is developing protocols and governance structures and helping with audit. Again, I can do that from home. So I sort of looked at, right, how many times can I be point of contact in a week, which obviously is only sort of 5 days in a week, unless you want to start eating into weekends. But one of the things I said to myself when I left the Rhinos as their head of medical for the rugby was I want to keep weekends precious. In fact, I've got a very extensive note section on the phone, which my friends will do ridiculously mock me for. One of the things in them is some sort of things that I try and keep in mind, and one of them says weekends are precious, because they haven't been for a large part of my career, or they have been, but they haven't been able to be for a large part of my career. So I try not to do too much at weekends now, apart from golf. So I look at the week, Monday to Friday, and I see how many times can I be there, and how many times do I want to be there, and then around that, where can I, with my children, where can I comfortably fit these extra things in? So I guess, whilst I work 85% NHS, I probably do maybe another 50% worth of private stuff in the week. So I work sort of maybe a job and a half, something like that, I guess, when you take into account evenings and mornings and things like that. So, but it allows me to have Saturdays and Sundays free, and that's crucial.
Yeah. And then how do you fit in e-recovery then?
So recovery at the moment is in its I'm going to say in its infancy. It's been going for a few years now, but we've obviously been working on it behind the scenes quite extensively, and now we're at a stage where we're, I think, 2 months away from being able to show the world what we've created, and hopefully then sort of that will be when more work starts. So at the moment, I am doing most of that, all of that work at home, aside from when I do my Nuffield clinic on a Friday, because Anthony Burns, who I work within that clinic, obviously co-founded Recovery, works there too. So we often have a good catch up and look at some spreadsheets and stuff at the end of that clinic. But when we built it, and if people like what we built, we'll then need to go out to various hospitals and organisations. I think that's when more face-to-face time will take over, and that's when I'll have to maybe then I will have to get a pen and paper out and look at the week again and say, right, what stops to allow me to do more of this. We'll see.
Yeah. Can you just tell me more about e-recovery and just like how it came about from your side? Ant did articulate it very well, but I'm intrigued by how you see it as well.
Yeah, so I mean, Ant's. I think he could sort of say this in his sleep now. He's delivered it so often. It's not to recover what Ant's gone over, but it's a great sort of digital healthcare solution to try and do exactly what I'm sort of hoping to do in the NHS, or helping to do in the NHS in the private sector. Just if you come to your private clinic appointment, you want to know that the doctor or surgeon you're sitting in front of is the right person to sort your problem. And we know, looking at the evidence from several government reports and also reports from within the private industry, that on about 17% of occasions, so not that few, it's not. Your soft tissue injury will turn up in front of an arthroplasty surgeon, and the list goes on. So from my point of view, it's again patient focused. If we can cut down the unnecessary time that a patient has to waste before they get the correct diagnosis. And so recovery looks at putting together the expertise of all the sports and orthopaedic and rheumatology doctors in the country, so that we know where to send people who can come through our service so they get that best service straight away. And what excites me about that is we're helping patients, we're helping doctors, because, you know, I don't want to sit in front of a patient who clearly needs an operation. That's a complete waste of time for them and for me, and it's, you know, it should have gone somewhere else straight away. So it helps doctors as well as it helps patients. But then there's all sorts of other opportunities with it, in terms of working with industry, in terms of working for education, creating platforms to train people. Like I say, it's in its infancy, but it's now to a point where we are very close to being able to launch it properly, which we're all very excited about.
No, definitely. And do you have any real vision as to where you think it may move to?
Well, that's a $1 million question. It's great. I mean, if it does what we think it should do and it can do, then there isn't really a reason why lots of people who work in the private sector will want to use it. It will be useful for private hospitals so they can streamline their referrals better. It'll be useful for other organisations such as the NHS, where we could help out as well, in terms of, again, getting it right first time, getting people in front of the right clinician at the right time. Just even down to the basic thing of a simple injury. And take proximal hamstring ruptures, for example. So when the hamstring comes off the ischial tuberosity, there aren't very many people around the country who manage those. And I know that because I had one in one of the early days of the clinic in Bradford. And I rang up one of my orthopaedic colleagues and said, who does them? And he was like, I don't really know. There's a guy down in Oswestry that I know might do it, but there's no one in Yorkshire I know that does it. Because again, that was maybe my naivety. I thought, it's an orthopaedic injury, surely someone here will do it, and it's not. So, but now we know through this database we created that there are several around the country. But we wouldn't have known that if we hadn't done the data, and that's the same for every organisation in an NHS trust. They don't have that information, so I think that'll be really helpful.
Yeah, definitely. It's one of those ones which I guess is hopefully why it really works out. Is you kind of think, yeah, that really does make sense. It's matching up the right people at the right time. So
yeah, I said that to my my dad actually. I was on the golf course and I was talking about it, and I said, this is it'd be good to get everyone to the to the right clinician. And he just looked at me and went, does that not happen? It's like, no. So yeah, I think there is a perception out there that you'll be referred and you'll be sorted. And like I said, that isn't the case.
Yeah, maybe he'll be excited about maybe getting some of the investment back once this all goes well for you.
If it goes well, yeah, I might take him for a pint. That's what I tell him.
Yeah. Very good. And then in terms of other things, what do you see? Is there anything else? I mean, you've already talked about a load of other things, like you've got a lot of moral causes that you want to do, get the NHS clinics working. Are there any other key things that you would like to see in healthcare, even if it's not particularly in your remit of sports medicine?
So the things that I've always been passionate about, I've had three things. So emergency medicine was a big passion of mine, certainly in my early career. And so it's no secret, it's on the news all the time. That's absolutely in bits at the moment, as is quite a lot of healthcare, but emergency medicine is really suffering. And so, if someone can figure out a way of taking that pressure off the clinicians that work in there, be it with urgent care centres, which will hopefully be cancer mainly departments, or more investment in staffing, both from a nursing and a medical perspective. That would be great to see that, but that's somebody else to think about. But I know there's loads of work going on there, but that's a really difficult nut to crack, if you like. Sports medicine, MSK medicine has been a big passion of mine, and so that's the kind of things that I'm trying to help with. And then the other thing that I dearly love in medicine is education. I absolutely love teaching and training, and so I'm blessed to do that again in my NHS practice, because I have that fellowship programme. And when I'm available, I'll go and do the induction days for the new junior doctors, or teach some of the trainees on MSK topics. And like I say, when and hopefully recovery takes off, there'll be ample examples where that can work. And I've worked with other people as well sometimes in private industry, where I help and can provide education sessions for them. And I just love it. I love delivering teaching, even down to trying to promote my clinics when I go to a bunch of GPs and give a talk to them. I love doing that too. It's always really engaging. I like teaching, I like taking the questions. So they're the three things that I think for me in healthcare: education, and then the ED and the sports medicine stuff.
And then, so for you coming through, like you like to educate and help mentor people and bring them through, are there any people in particular that have been a big influence for you in your career?
Yeah, well, without doubt. So there's been, I mean, going right back to school, before, I mean, I knew I wanted to do medical school at this point, but I had a teacher who taught me biology called Nick Porteous. And he was absolutely phenomenal as a teacher, both in terms of being able to get through the information that I needed, but also do it in a way that pretty much the whole class responded to. And there was a lot of personalities in the class, a lot of different people, but he managed to control that really, really well and be a friend as well as a teacher. So he was a massive influence, and again, you know, made me do what I need to do in biology, and I've got no doubt about that. So that he was a big influence. Through the sporting sort of perspective, I had a couple of people in the sports world that I've reported into, managers at Leeds Rhinos and stuff, that have been wonderful with me, and again learnt leadership and communication through them in terms of the calmness that they can exude in situations that are perhaps not where you could quite easily not be calm. So they've helped me a lot. Through medicine, there's been a couple of doctors that I've worked with sort of in my ED career that have been fantastic. There's been a doctor he's a good clinician, but he's much more, he's a great mentor. So he's Rob Halstead. He works at Bradford in the A&E department. He's a really good guy. He's helped me out of a couple of situations in my early career where I've had to handle things non-medical. There was one complaint I remember that he was brilliant at talking me through, and there was another issue that I had involving some governance thing that he was just great at just being calm and seeing the wood for the trees. So he's been a phenomenal sort of guide, and he's a good friend now actually. So that's really good. And then there was a doctor as I was training who just seemed to know everything. There was no question you could ask him that I didn't expect an answer from. And so that without doubt drove me to try and be as good as I can be in MSK and sports medicine now. So I still sort of read articles, read up on anatomy, still try and be as good as I possibly can be. Because if I'm teaching people, then my mantra is, I need to know all this stuff. Otherwise, what was the. I say to my trainees all the time, anatomy is one of the cornerstones of MSK medicine. You can't tell me what it is, where it attaches, what it does. How are you going to tell me it's not working or it's broken? And so I think, well, if I'm saying that, which is a nice little soundbite, I better walk the walk as well, learn that stuff. So he drove me to be better clinically. So yeah, there's been a few.
Yeah. Did he check that he was definitely right with his answers, or did he just say it with complete confidence?
You know what? With people like that, it's brilliant, isn't it? You probably check the first couple and then you just assume. So he could be telling me all sorts, but no, he said it with confidence. He seemed like he knew what he was doing.
Yeah, I'm sure he did. And then what would your advice be for people wanting to get into this area, whether it is doctors, physios, or whatever, anything in the medical area?
So be proactive. It's really competitive, still being a medic and being a physio. So be proactive. I've just recently had a physio, well, she's soon to be a physio student, a mature student, went away, I think she's 1 degree, went away, had children, now has come back and she's decided physio is her calling. And she's come to observe 5 or 6 clinics with me, both privately as well as in the NHS sector. She's taken, she's arranged childcare to be able to come and do that. So she's that kind of drive, that kind of you can tell about that when you interview someone, when someone comes to see you. So be really proactive, gain experience where you can, which involves sending emails out and getting lots of rejections. The number of emails I got when I was at the head of medical at Rhinos asking me, could I do some work experience? And invariably the answer was no, because we didn't allow that in the elite sports setup for the majority of the time I was there. And that wasn't my decision, that was sort of coaching and higher up. But you don't know unless you ask, and then that transfers through to your career. If you want something, then just go for it, because keep asking. You can only be told no, and the more you persistently ask, the more it seems to happen. So communicate well, be persistent, and be good at what you do. Take the time to really learn what you do.
Yeah, it's interesting though when we've chatted previously that the non-clinical skills seem to be such a massive component of. You mentioned it earlier on about that, 20% maybe being that aspect and 80% being everything. I think that's such a good message for any walk of life, but it's interesting that you're still saying it in a medical world.
Yeah, absolutely. Yeah, communication is, and leadership and all the non-technical skills. And if you look at medical training now, more and more of it is around the non-technical skills now. There's only so many times you can learn the advanced life support protocol before you've got that. But when you get into that resus room and someone's heart's not working, you know your protocol, but then controlling your environment becomes far more significant.
I think it's interesting, even just in school life or whatever it is, that there's not really much emphasis put on educating people to understand how to manage money, business. You mentioned being calm before, and I know for sure, when I'm running the company, it's like, it gets stressful at some points, but it's important to try and avoid communicating that at certain points. So how do you think that could be? I mean, that's a big question. I'm not expecting you to answer this one as well, but is there any ways in which you think in your environment that could be better supported?
So, I mean, when you look at, again, going back to sport, when you look at the academy in most clubs now, they won't just be teaching them football, rugby, cricket, whatever it is. They will have lessons on life skills, teaching them a trade or managing money, and then there are sessions on that, managing mental health, managing all sorts of things. So I think, if they can do it there to the youngsters, why can't we do it in schools to the youngsters? There's a lot of focus, obviously, necessarily on the subjects that matter, the maths, the English, the sciences. But if you bring in financial awareness, some mental health awareness, some physical awareness, my clinics would be a lot less busy if we could put in some sort of posture, balance, and core work in school than is. So I think from a young age, like everything, learning a language is easy when you're 5, not so easy when you're 50. It's the same thing. Learn it young. So bringing that stuff into the young age and then following it through university and beyond, or college and beyond.
Yeah, no, I agree. And then last question, are there any books that you read that are non-clinical that help you with, I don't know, any of your mindset or any particular professional development ones?
Yeah, from a book. So I mean, the Steve Peters book, The Chimp Paradox. I always say that. That's nothing new. I'm sure many people have read that. I think that's great. I think Steve was actually my 4th year medical school tutor. He was an absolutely lovely man, and obviously very, very, very good at what he does. So I like that book a lot. But then I listen to sort of podcasts and stuff aside from books. So I you pick the people that are sort of going to drive sort of your learning. But I like the Tim Ferriss podcast quite a lot, and I like some of the people that he interviews. Some of the people not so good, but some of the world leaders, the mentors, they're really good to listen to. So I get a lot of sort of information from that. Yeah,
4-hour work week. That's still the goal, isn't it?
It is. It's very good.
Brilliant. Look, I really appreciate your time, Al. Thank you very much for that. It's good. I'm glad we touched on some of the non-medical stuff as well. So I think there's a lot of good messages there. But thank you for your time. And I'll look forward to, I'm coming to see your clinic in Bradford. So I'm very much looking forward to seeing that soon.
Yeah, we look forward to having you, Andy. Thanks so much, Andy, family. I really appreciate this. Enjoyed it.
No problem. Cheers, Al. Thank you.
Cheers. Bye.